Our next speaker will be Dr. Budoff. So Dr. Matthew Budoff is Professor of Medicine at the David Geffen School of Medicine at UCLA, as well as being the Endowed Chair of Preventive Cardiology at Harbor UCLA Med Center. He graduated from UC Riverside as an Alpha Omega Alpha and from George Washington University School of Medicine. He's authored or co-authored more than 50 book chapters and over 1,000 articles, numerous research grants from NIH, as well as being appointed in 2015 as the Endowed Chair of Preventative Cardiology at Harbor UCLA. He's been recognized for his work by the Society of Cardiovascular Computed Tomography, for which he received the Gold Medal Award, and recently designated as Master of the Society of Cardiovascular Computed Tomography. He was recently named Cardiologist of the Year by the American College of Cardiology, California chapter. We're waiting for them to change the name of cardiac CT to the Budoff CT. But he's here today to talk about the role of imaging in cardiovascular risk assessment.
Well, thank you, and thank you for having me back. That last talk was great. It reminds me of how we used to get patients to take niacin, which is just another supplement or B vitamin, and we tell them that you're going to feel the cholesterol just flush right out of your system. The problem was when they stopped flushing, then we had an issue. But anyway, so let me talk to you a little bit about something different, about how we can use imaging to help encourage patients to do the right thing, whether it's taking a multivitamin or taking a statin or anything in between. Really, behavioral issues are tough, and I'll show you where we are with CT and some of the new cholesterol guidelines and where we're going. These are my disclosures. So coronary calcium is a very simple test. I've spoken to you before about this, but really just this concept that we can show patients not just their percent chance of getting something, right? You have an 8% less chance or a 25% less chance of getting a disease, but we can say you have the disease. And that's really, really impactful, right? So if you go back to the best epidemiologists, there was a guy named Sir Geoffrey Rose. He was an epidemiologist in cardiology and in the UK, and he used to say that the best predictor of a disease is the early manifestation of that disease. And this is the early manifestation of heart disease. So it's going to be a better way to identify who's going to get heart disease than a C-reactive protein or a lipid panel or a prevent risk score, because it is the disease. And we can show patients that they have the disease at a very early stage where it's still eminently treatable and they haven't had that big event, the heart attack that kills 1/3 of people right out of the gate, or a stroke that disables people. And we can get to this early. And it really helps, because one of the biggest factors we have is we can prescribe all these therapies, and we have unlimited therapies and many more coming down the road that are useful. But the bottom line is, patients have to open up that pill bottle and take that pill every day, or take that injectable and inject themselves every week or 2 weeks or monthly. And that's more work than just us putting an e-prescription in or writing them a prescription to use a therapy. So they need to be convinced. And this really is what we call a picture is worth 1,000 words, where we show them this. And I've converted a lot of patients who would not take a statin because Dr. Google says statins are bad and that's going to hurt them, right? And now I show them, well, you have this plaque and it's pretty advanced. These white spots in your arteries are starting to block up your arteries. And now they're like, okay, well, maybe I will give that a try, that evil medicine. And then 95%, whatever that number is, don't get side effects. And then they realize that it's not as bad as was advertised. Calcium is really what we call the tip of the iceberg. It really only represents a little bit of the overall atherosclerotic plaque. There's fibrotic plaque and the more dangerous lipid-rich soft plaque, and then there's even vulnerable plaque at the very bottom. We can't see that with a calcium score, but a calcium score gives us an idea of about how big the calcium score is how much overall plaque you have. So the more calcified plaque you have overall, on average, the more plaque in the coronaries you have, and that's a bad thing. So, when the Titanic is going downstream and sees an iceberg off its bow, it didn't say, let's send divers below the surface to see if there's something to rip the hull. It knew that it was in trouble, and it knew that it's going to hit something. So you have a lot of coronary calcium, you have a patient who has atherosclerosis, and the more calcified plaque they have, the more total plaque they have on average. How well does it predict? And we've done large studies in multiple different ethnicities. Here's just a blow-up of one of them. They all perform the same in the multi-ethnic study of atherosclerosis, a big NIH cohort that we're still following. It's now is started in 2000, so it's actually now over 25 years of follow-up. This is the first 12 years of follow-up, but you can see if they have a score of 0, no detectable calcified plaque in that very light line at the bottom, that their event rates are very low. And as they have some plaque, their event rates start to go up in light gray, and as the lines get darker to dark gray, a score over 100, high risk, and a score over 300, very high risk. And I'll show you how our new cholesterol guidelines that just came out a couple months ago have now strongly incorporated coronary calcium scores into the algorithm of decisions, because the higher your risk, the more we want to match intensity of therapy to intensity of risk. So the higher the risk, the lower the LDL. Very simple. And what about how high a risk are you without having an MI before you end up with a myocardial infarction? Or at the same risk of somebody who suffered a myocardial infarction. So again, another study, different than the last one, but blue, calcium score of 0, low risk of having anything bad happening, heart attack, stroke, major cardiovascular death, revascularization. Things don't happen when you don't have a lot of coronary plaque. Red, a little bit of plaque, your risk doubles. Black, your risk doubles again when you have a score over 100. That's our threshold. And then if you have a score in purple of 300, your risk doubles yet again. So we're talking about now an 8 to 10 times risk. When Dr. Ridker talks about C-reactive protein, he says, oh yes, CRP is definitely a risk factor. The hazard ratio is 1.17. If you pool all the trials, that means you're 17% more likely to have a heart attack if your CRP is elevated. This hazard ratio is 10. That's 1,000% more likely to have a heart attack if your calcium score is up. So if you're going to spend the money on a test, we are literally 80 times better, more predictive than a C-reactive protein, if you believe the person who literally invented the concept of using hsCRP in our practice. But look at that purple line, high risk. There's a yellow line of different patients, but in the same cohort, have already had a heart attack. And look at their risk. And those two lines are almost perfectly superimposed. So we can predict who's at the same risk as a post-MI survivor with that yellow line and the purple line being the same. So when your score is above 300, your LDL should be below 55 because you're at the same risk as a post-MI patient. What about soft plaque? Well, soft plaque is not highly predictive by itself. This is a study of 23,000 patients. That red circle got pushed down a little bit, but no plaque at all in bronze equals low risk. Little bit of plaque, soft plaque, calcium score of 0, no calcified plaque, but a little soft plaque, exactly the same risk in light blue. And your risk only starts to go up even just a little bit if you have a 50% blockage from non-calcified plaque. So I trust a score of 0 because it's as good as if I added in a non-invasive angiogram, which we'll talk about in a minute, in these low-risk people. It doesn't add a lot to know if they have some mild soft plaque. Now, a lot of us, if we see soft plaque, whether we see it's a stenosis in the cath lab of 20 or 30%, or we do a CT angiogram and we see a little bit of plaque, we're like, oh, you have the disease, we should start treating it. But the data is not compelling that really changes their risk very much until they move to the middle category where they start getting a little bit of calcified plaque. Now they have mixed plaque, that's more dangerous, calcium and soft plaque, and their risk starts going up proportionally. What about aspirin? If you know when to use aspirin in primary prevention, we heard a nice talk and they alluded to the Physicians' Health study where all men benefited from aspirin, and it was recommended that all intermediate risk or all intermediate aged men go on aspirin based on the Physicians' Health study 1. The U.S. Preventive Task Forces a few years later said, no, that's overstated. Nobody should take aspirin. Then they said, no, we're wrong. Men should take aspirin to prevent a heart attack. Women should take aspirin to prevent a stroke because they're different. Then they came out a few years later and they go, no, we were wrong again. It's men and women both benefit from aspirin, but only if they're high risk and have a low risk of bleeding. So like nobody knows what to do, and the best thing they could do is probably disband the U.S. Preventive Task Force, but that's not yet happened. But because literally it's like a ping pong ball of decisions, but they have no idea what to say anymore. They keep saying things is the problem. Like I would say, if you don't know, just don't say anything, but that doesn't seem to be their motto at their agency. But anyway, I can tell you, at least from some very large observational studies, and this is just one of them, but there's about 5 big population-based studies that looked at least at actual bleeding rates and actual event rates based on the calcium score and based on their risk of having an event. And in all 3 categories, the data is very similar. If you have no plaque at all, in yellow, no calcified plaque, a calcium score of 0, the number needed to treat is a high number. And the number needed to harm is that red line. And that means that you're going to harm more people than you benefit if that bar exceeds the red line. So at a score of 0, if you put them on aspirin, you're going to have to treat 2,800 patients to prevent one event. You're going to cause 4 major bleeds in that population, so 4 to 1 harm. But if you start looking at calcium score above 100 in light green, regardless of whether you're low risk, intermediate risk, or high risk based on risk calculators, if you have a calcium score above 100, the risk benefit is favorable. It's about 3 to 1 or 2 to 1 favorable in favor of treating patients. Because if you put a patient with a calcium score above 100 on a low dose aspirin, you're going to prevent at least 2 to 3 MIs for every 1 bleed that you cause in that group. And if you get to a score above 400 in dark green, that number goes up as high as 8 to 1 benefit. So the guidelines have generally adopted this concept that this calcium score, if you have a lot of plaque in your coronaries, a low dose aspirin may be useful if they're at low bleeding risk, of course. So not randomized trial data. We went to Bayer, we went to the NIH. Nobody wants to pay for another aspirin trial, but I do think that this is a consistent finding across multiple studies and a consistent effect. So it has worked its way into the guidelines. So back to this concept of this, a picture's worth 1,000 words, we've demonstrated that it does more than just motivate good that predict events, that it motivates good behavior. And there's been a number of trials. This is a trial we did with Dan Berman and Cedars-Sinai, 2,137 patients. It was sponsored by Mr. Eisner, so it's the Eisner trial. We took asymptomatic people and had them speak to a nurse practitioner about their health, about their guidelines, based on their LDL, based on their blood pressure, based on their risk. Or we had the same thing and they got a coronary calcium scan, and then that same nurse practitioner went back and talked to them again saying, well, based on your calcium score, we want to make some adjustments. And this is what happened. If they got a calcium score 4 years later, so we're not talking about our New Year's resolutions, which are, for all of us, are long gone, where we stay on things for weeks, maybe a month if we're really dedicated, and then we'll wait for next January to start over, going to the gym or whatever we were planning on doing. But this is where we are with 4 years down the road after having that intervention, showing them that they had a calcium score. Their LDL was 3 times lower, almost 30 milligrams per deciliter lower on average than if they didn't get a scan. Their blood pressure was twice as well controlled. They were more likely to still be exercising 4 years later, more likely to get a new lipid therapy, blood pressure therapy, aspirin therapy, and their adherence, if they were already on a statin, was higher because they saw that they had plaque and they saw that plaque caused or was them and not a population. This personalizes medicine to the individual. It's in the guidelines. This is the AHA Presidential Advisory from the American Heart Association. You can see CAC greater than 0 favors statin use if they're at intermediate risk, and a calcium score of greater than 100 favors aspirin use if low bleeding risk. So what about, and let me just point out one other thing, they also mentioned consider agents for ASCVD risk reduction if their calcium score is above 100, including PCSK9, which I'm going to come back to, but this was in 2023. They were quite insightful because there's a study that came out since then that shows that PCSK9s are beneficial if your calcium score is above 100. So then the new 2026 guidelines come out for cholesterol, and one of their top 10 new findings, number 7, was calcium scoring in men of 40 years of age or women at least 45 years of age. You need some time to develop calcific plaque if you're going down that road of atherosclerosis, can improve risk assessment and guide LDL and non-HDL goals. So the 2018 recommendation was a class 2A recommendation. It's reasonable to use a calcium score. 2026 class 1 recommendation, calcium scores should be used for further risk stratification and to guide a decision to withhold, postpone, or initiate therapy. So we now went to we should be doing calcium scoring. Another thing that they pointed out at the bottom, which is important, is incidental coronary calcium. Incidental coronary calcium is you find it on a lung CT, or you find an abdominal CT and the radiologist says there's a lot of athero in the aorta. That's atherosclerosis as well, and we should act on that, even if we don't have a score that goes along with it. So these are the guidelines. They gave a class 2A recommendation for patients to go on a statin if they have just a little bit of plaque, a little coronary calcium, because they have the earliest manifestation of the disease. But starting with calcium score of 100, a class 1 recommendation, start LDL lowering therapy, get the LDL at least 50% down, and get an LDL less than 70 milligrams per deciliter. Now, there was a trial called Vesalius. Vesalius came out right after or right at the same time as these guidelines, so they weren't fully embraced. But Vesalius randomized patients with a calcium score above 100 to a Repatha, evolocumab, or placebo, a PCSK9 inhibitor. And one of the major it wasn't the only way to get into the trial, but it was one of the major entry criteria was having a calcium score above 100, and there was a 25% event reduction and a 36% MI reduction in that population. So we have randomized prospective placebo-controlled trials that show if you have a calcium score above 100 and you go on a PCSK9 inhibitor, you have less events. So if you can't get them to goal with a statin, we have great evidence that we can go and get them to goal and benefit our patients. They lived longer, 20% less death in that population who got put on a PCSK9 if their calcium score was above 100. As the score goes up, the LDL targets go down. Above 300, we start talking about LDL goals of 55. Above 1,000, which is a crazy amount of calcium, everybody should be below 55 and consider getting their ApoB levels below 55 as well, which is a little bit harder to do because ApoB is not just LDL, but it includes all the other cholesterol parameters. And finally, they talk about incidental CAC. Again, we're doing more lung cancer screening. When Dr. Khan does his PET scans, they can get, sometimes if they have CT correction, they can get little bits of idea of whether there's plaque in the coronaries, or you get that from even a chest x-ray, which would be a lot of calcium if you can see it on a chest x-ray. But you want to make sure that if you identify these patients with athero, that we get them on therapy, even if it's not a dedicated coronary calcium score. So when we think about where to use this test, we use it for patients who are unsure of whether or not they need to be on therapy. And that's usually an intermediate risk patient, which historically has been defined between 5 and 20%. If they have a family history, I find it very helpful because we don't know the genotype. We don't know the genes that patients get. I don't know if I got the gene from my dad who had early heart disease or not because we don't know what gene it is yet. But I can tell the phenotype I don't have the same calcium score my dad did at my age, so I know that I didn't get the genetic predisposition for atherosclerosis. So I can sort out family history by looking at the phenotype, the calcium score. Again, statins, we can get them to do stuff. It's great for motivation, and it can help us with non-statin therapies as well, things like PCSK9 inhibitors. So the interest in cardiac CT, we've been doing calcium scoring for 30 years. Dr. Agatston from the Agatston score, he invented this, and he also did the South Beach diet, so he's a couple nice things to his name, but he invented the calcium scoring in 1990, so it's been around for 35 years. And we're starting to see big uptake, but still it took a long time. But the real driving force is now CT angiography and how we can drive imaging forward by getting more information. And this is a pretty simple test. It requires a little bit of contrast. It's about a 7 or 8 second breath hold, so it's not a long breath hold anymore. And we get a lot more information. We don't only get information about calcified plaque, but we get the soft plaque. We also get stenosis, and I'll show you we can even do AI now, the dreaded AI, and get things like flow down the vessel, and we can get plaque volumes, total plaque volumes. But even if you just look at the old data, this is from the old 64 slice data from the early 2000s and the late 1990s, the negative predictive value, if the CT angiogram with an old 64 slice scanner says there is no significant blockage, and you took them to the cath lab, 99% of the time you'd be disappointed because there is no significant blockage. It'd be correct. So we can rule out obstructive disease with this test, but more importantly, we can see plaque. And but the biggest barrier to plaque imaging has been, and CT angiogram has been, the radiation exposure. We don't want to give patients a lot of radiation and cause downstream harm. But with the new 256 scanners, the dose of radiation is below background radiation. So imagine you scan a 60-year-old male or a female in your practice. They've been alive for 60 years. They've gotten 3 millisieverts a year on average, mostly from cosmic rays, but from other sources. And they have 180 millisieverts of exposure without ever getting any medical imaging. If I add another 2 millisieverts for my CTA, they went from 180 to 182. That's probably not the break point to develop cancer, is that extra 2. So we're pretty confident that this is a very safe and effective radiation exposure. It's more than a calcium score, which is the same as a mammogram, but I've never had a woman tell me I'm not going to get a mammogram because I'm worried about the radiation. There's other reasons why you don't like to get mammograms, I recognize, but it's not a radiation exposure problem. So what do we get from the CT angio? Well, we see the arteries really well on the left. That's what we used to see, but now we can see the types of plaque in the middle and the percent blockage. And then on the far right, we start getting advanced AI, and we can now see the flow down the vessel, and we can see how much millimeters of plaque there is in non-calcified plaque and calcified plaque, and get more information for the clinician and for the patient. And it's accurate. It's very accurate. It's up there with PET scanning as far as diagnostic accuracy, and it's better than SPECT or MIBI or technetium that we used to use that I think is not quite as accurate. It misses a third of people who have severe disease. It says that their arteries are normal, so I'm not a huge fan of SPECT anymore. I think it served us well back in the 80s and 90s and early 2000s. And we're seeing decreased use of that. I know here you have PET, which is much better. MRI, cardiac MRI, just not perfect yet. And stress echo, a nice test because there's no radiation, but the sensitivity has always been low. It misses disease. When you see an abnormal stress echo and that wall stops moving with exercise, that's a good finding, but you miss about half the people who actually have blockages and the stress echo doesn't see it. It's just a methodological problem because they have to be on a treadmill, and then we rush them to a table, and then by the time we image them with the echo probe, their wall has gone back to normal. It's just not an optimal way of seeing the heart. But what test is best for outcomes? Well, the Scott Heart trial was a 5-year prospective randomized trial of over 4,000 patients, and just said if you get a CT first instead of a stress imaging study or a stress test, you have a 41% less chance of having an MI or a death. It's a pretty good endpoint. That's better than statin use, is just getting the right test. So test selection is important, and CT angio is a better test because it not only shows us who has blockages more accurately, which is very important, but it also shows us who has plaque in their coronaries, better than a calcium score, because we can see the soft plaque and we can see the vulnerable plaque. So we can say, oh, Mr. Johnson, you don't have a high-grade blockage, that's great, and if I did a stress test, it would be normal, but you have a lot of plaque in your arteries, a lot of 30% blockages, and any one of those can rupture and cause a heart attack. So I'm going to put you on some medicine, whether that's lipid lowering or whether that's supplements or whether that's blood pressure control or whatever, or diabetes meds, whatever you're going to put them on. That's going to be an intervention that you can't make from a negative stress test, because a negative stress test means you don't have a high-grade blockage, but it doesn't tell you at all about whether they have these plaques that can rupture and kill you. So we found the same thing in the PROMISE trial, 10,000 patients done in the US. These are the diabetic cohort where the event rates were a little bit higher, but it showed the exact same thing. If you had a CT first instead of a stress nuclear, mostly in the US at this time, it was a 62% reduction in events by getting that CT instead of the nuke. So we have great data to show in randomized prospective trials that getting the right test is important to inform us on what to do next. So we'll skip the ischemia trial, but I did want to show you the guidelines, and the guidelines don't say to do only one test. They don't say just do a CT or just do a functional test or just cath everybody. It's based on risk. And these are the European guidelines, but the US guidelines are exactly the same. They just don't have the pretty picture. I'll show you those in a minute. But they say, if you have a lower probability of disease, like most of our patients, they have a little bit of atypical pain, or they don't have classic angina with pressure, and every time they walk, they have to stop because they get chest pressure, and nitro makes it better. But if they have a little bit of atypical pain, CTA is preferred. If they have more advanced risk factors and more classic angina, then a functional imaging test is preferred. And if they're a slam dunk that they have classic angina and they have diabetes, hypertension, high cholesterol, and they smoke, then just go straight to the cath lab because they have very high probability of having a disease. And you don't need to do multiple tests to get them to the cath lab. So this is a stratification that we still use. It favors CT about probably 80% of our cases. If you look at a stratification of who comes in to see a cardiologist, it's about 80% of patients will be low to intermediate risk, which would favor a CT. In primary care, that number would probably be about 90%. But again, you have the classic patient diabetes with great symptoms of chest pain, or an older patient with great symptoms of chest pain, go straight to a functional test. So the guidelines endorse that as well. These are our 2021 guidelines, and they were most favorable to CT angiography. So CT angiography, was the only imaging modality they gave a class 1A recommendation to, where they said CTA is the best test. And they said it's effective for diagnosing coronary disease, for risk stratification, and for guiding treatment decisions, which is really important because that's what we want. When we order a test, we want it to help us decide what should we do next. That's what it says for CT. This is what it says for functional testing, including SPECT, including MRI, including stress echo. It's useful for the diagnosis of myocardial ischemia. Class 1B recommendation, a little bit lower, and a hyphen based on non-randomized data, so just on observational studies. Diagnosing myocardial ischemia, nothing about guiding treatment decisions, nothing about stratifying patients' risk. And if you don't think these two are different enough, I'll bring you back to the main, to the group of organizations that signed on. There were 8 organizations here that signed on. There were 9 at the beginning. And the 9th one was called the American Society of Nuclear Cardiology, which withdrew their name at the end of the process. They were involved in this process of writing the document, but when it recommended CT angio more strongly than nuclear imaging, they said that doesn't serve our membership well, so we're going to take our name off the document, which I guess is a good steward of their membership, but may not represent what we hope from an academic imaging society in cardiology. But they were upset, and as children will do, they took their name off the document. I don't think it changed that much, but we don't have their support. Anyway, so this is what Val Fuster from Mount Sinai, he came up with this paper just before the guidelines actually, but kind of a nice algorithm where we can see how things layer in. And he said if you have any type of chest pain, outpatient, we're not talking about acute chest pain, but you have an outpatient chest pain, you do your initial medical treatments, and then you can get a CT angiogram to further risk stratify them. And if they have no athero, then you can de-escalate therapy or not worry too much. If they have little bit of non-obstructive disease, those 30% blockages, we can increase our medical therapy. If you have extensive disease, you really intensify medical therapy, and you can now start thinking about revascularization if medical therapy fails. And if they have high-risk anatomy, which we can see if they have a left main, or we can see if they have multivessel disease on the CT angio, because we can see each vessel, then you'd send them for not only medical therapy, but also layer in revascularization. So this is our probably more of a contemporary management strategy that a lot of us are using. But the age-old debate still raged on. Like, we have great anatomy. I can see that blockage in the left anterior descending on the left. Looks like a pretty significant blockage. But I don't know if it's functionally significant. Is it really causing a problem, or is it just kind of looks ugly? And should I leave it alone? And that's where we relied on functional testing. But now with AI, we can actually get more information from that picture on the left, from that anatomical test on the left. We can add in flow. Through AI, we can estimate what the flow is down that vessel. And when it turns red, that's a bad sign. That means that lesion in that left anterior descending is flow limiting and probably benefits from revascularization. So we have some great data. Now, does it really help? Well, the guidelines say the only Class 1A test is a CT angiogram, but they also said that this method of analysis, FFRCT, to look at the flow down the vessel with the CT, is a 2A recommendation that provides, and it says on the right, guiding to be useful for diagnosing vessel-specific ischemia and to guide decision-making in terms of revascularization. So it guides decision-making. Again, an important caveat. If we're going to order a test, it should guide decision-making. And the guidelines also said that about FFRCT, which further pissed off the American Society of Nuclear Cardiology. That was another reason they said, we don't like that FFRCT guides decision-making and our nuke does not. But anyway, so we now have these tests that we can use, and you can see that PET scanning in green slightly outperformed CT angiograms, and nuclear wasn't great. Nuclear was in that orange bar, at the bottom, 70% accurate. PET is much better, almost 90% accurate, so that's a great advancement. But if you add in FFRCT, CT angio leapfrogs PET and now has a 94% area under the curve or accuracy. So we can become more accurate in who needs revascularization. So let me just show you a study that I think is very impactful to show you that if we do this is a randomized trial data. There wasn't 100 patients per arm. There was over 1,000. This is per 100 patients, a terrible way of portraying the data, but that's how they did it in the paper. So per 100 patients, if you did functional testing mostly or traditional testing, they end up about 18 patients go to the cath lab. Only 6 get revascularized, and 12 out of 18, or about 67%, are found to have no obstructive disease. So false positives, 2/3 of patients. If you do the CT angio arm, that's what they call the precision pathway. They get a CT angio. We only cathed 14 patients. We got less people to the cath lab, higher specificity, but of those 14, 10 got revascularized, an overall revascularization rate of 72%. And only 4 patients out of 14 ended up having non-obstructive disease. So we can get rid of the false positives in red, less normal caths, but increase, double the number of PCIs. So interventionalists love CT angio because it gets more people appropriately to the cath lab for revascularization and less normal coronaries, which are not rewarding for most patients. And the problem with a normal coronary is you tell the patient, good news, your nuclear was false positive or your stress echo was a false positive, you don't have any major blockages. They say they feel great until about 6 weeks later they have a heart attack. Why? Because they get that bill from the cath lab. Right? They get a $15,000 bill from our friends in interventional cardiology who said your coronaries are normal, and now the patient have their MI anyway. So we could hopefully clear that up. So let me just finish with this one concept of, and we can do plaque imaging to further stratify risk, but I want to show you how we put it all together. So if you have a patient who has no flow-limiting lesions on a CT, FFR CT is normal, the normal flow, and they don't have a lot of plaque. This is the AI plaque quantification, not a calcium score, but total plaque volume, their risk is very low. If they have no flow-limiting lesions, but they have a lot of plaque, they have events, we call them, these plaque events occur, but they occur a couple years later, so you have time to intervene. Because you know that they have a lot of plaque, we don't want to just watch them over time. This was an observational study. If they have a lot of flow-limiting lesions, they have early events. So you see these FFR CT events because they have flow-limiting lesions right out of the gate, but if they don't have a lot of plaque, that plateaus. And if, unfortunately, they have both flow-limiting lesions and a lot of plaque, their overall event rates are really high because they have problems with flow, early events, and then they have a lot of plaque. They get late events. So we can treat the plaque and treat the FFR CT. So I'll leave you with this concept that we can see the arteries. That's a nice picture of a stent. We can see down the vessel. We can see bypass grafts with great accuracy. But overall, we can use this tool to identify patients who need preventive therapy. It stimulates them to be better patients because they know they have the disease, and we can do better for our patients. Now, it's not a perfect test. With cardiac CT, if they have a high calcium score over 1,000, CT angio is not a great test because we can't see through the calcification. If they have a lot of stents or we can't get their heart rate under control, we get into trouble. If they have a really high pretest probability, they need a cath. We don't need to do a CT angio to give them contrast and radiation to then take them to the cath lab to give them more contrast and more radiation. So if you really think they need a cath, send them for cath. And finally, if they have renal insufficiency or severe contrast allergies, this is not the best test for them because, again, we don't want to harm them to then say, yep, you have disease and now your kidneys are shot and we don't want to cath you and fix the problem. The last thing I'll just show you is these beautiful pictures from a future of these better imaging scanners called photon counting scanners, which are out there, but there's not many of them yet in the United States, but they're coming. They improve image quality, and we go from on the left, our 64 slice CT that's supposed to be a right coronary artery with our current 256 in the middle. You can see the artery pretty well, and on the right, you can just see so much better detail. This is the same patient scanned with 3 different scanners. So I'll leave you with this concept that I've been battling for my career. All truth passes through 3 stages. First, it is ridiculed. Second is violently opposed. Third, it's accepted as being self-evident. And I think this concept of seeing the plaque and the stenosis, and now with AI quantification, we can do a lot to help diagnose our patients. So thank you very much.
We have a problem convincing hospitals because they feel they make more money admitting the patient. And from the outpatient standpoint, we need to get commercial insurances to pay for these.
Yeah, so it'll get a lot better, both for calcium scoring, because it's a class 1 indication in the new guidelines, so that always leads to reimbursement. Not quite there yet because it just came out a couple months ago, but CT angio is pretty good now for big commercial payers. Medicare is a slam dunk. Everybody can get a CTA. But we're getting better. Blue Shield is good. United is good. Blue Cross Anthem is not good. HMOs are mixed, but I'll tell you, Kaiser is Northern California switching a lot of patients over. They're doing a lot of conversion from nuclear testing to CT angio, and we're starting to see that in Southern California, Kaiser as well. So you'll see this shift over time, but you're right, it's a payer issue, it's a reimbursement issue, and it's a have enough scanners to do the work issue.
Question.
Yeah, so the question is about a correlation between calcium scoring or CT in the arteries and the carotids. They're similar. They're both vascular beds. They both get athero. They're not exactly the same. Carotid arteries are actually elastic arteries, so if you give nitroglycerin, they don't do anything, where coronaries are muscular, so if you give nitro, they open up. So there are slightly differences in the vascular bed. We're pretty comfortable with a calcium score of 0, because if you have no plaque at all in your coronaries, not even a speck, it's unlikely you're going to have much in the carotid, but we can see sometimes carotid plaques in the absence of coronary. So some people like to do carotid ultrasound still, or carotid thickness testing, but the plaque is more important than how thick the carotid is. The thickness is not reliable. Plaque in the carotid is a bad sign. So if you're going to do carotid imaging, make sure they tell you if there's a plaque there or not how thick it is. We don't care about thickness anymore.
Matt, if you replot the MESA long-term data looking at standardized percentile rather than absolute calcium score, what do 12-year data look like?
Yeah, so that's a great question. Yeah. No, so that's a great question, and I should have pointed that out more. So the guidelines say score greater than 100 or above the 75th percentile. That means that when you compare patients to their age-matched sex and age and race, ethnicity, you can find out, do you have too much plaque for you at your age? So a 45-year-old woman who with a score of 1 or 5 is abnormal. They shouldn't have any plaque yet. So they're on that slope where plaque is going to beget plaque, and they're going to go up. So if they're above the 75th percentile, and there's something called the MESA risk calculator, it's very easy to use, you can plug in their age, their sex, and their race, ethnicity, and it'll tell you what the average calcium score is. Or you can put in their calcium score as well, if you have it, and it'll tell you what their risk is. It'll calculate their risk based on that. So plotting them based on their percentile is helpful, but a better predictor is absolute plaque. So I did a study where we said 75th percentile versus a score of 100, and 100 was a better predictor of who's going to have an event, because if you have a lot of plaque, doesn't matter if you're young, old, intermediate, you have a lot of plaque, you're going to have more events than if you have a score of 2 as a 45-year-old female. Score of 2 is not a lot of events now, it's a long-term risk of events. So we do use the percentiles as well. Thank you, Dr. Wright.
Another question here.
Yep.
So to clarify, when we see on a random X-ray calcification of arteries, whether it's in an ankle or in the aorta, does that an indication to immediately order a CTA or to just refer straight to cardiology for a possible cath?
Yeah, so don't send them straight for a cath if you see a little bit of plaque, because they don't have any major blockages, probably, unless they have symptoms. Cath is for symptomatic patients with high risk. If you see a little bit of plaque in the periphery, whether it's on a X-ray of the foot, and they say there's some arterial calcification, or a lung CT for lung cancer screening, and they say there's coronary calcium present or atherosclerosis present, you're just supposed to start treating them. The indication is to get their LDL lower. So it's not a referral to anybody, it's an initiation of lipid lowering, however you want to do that. The guidelines favor statins over red yeast rice, but there are different ways of skinning a cat, and I think we already heard of some alternative therapies that may or may not be useful, but I would say if you see plaque, just treat it. You don't need to send them, certainly don't send them for a cath, please. And they don't need to see a cardiologist for a little bit of plaque in their lung, CT. If they have a little bit of coronary calcium, the good guideline is that they have some athero, and you should start them on preventive measures, whatever you think preventive measures are.
The LDL less than 55, how did we come up with that number? Is there enough studies to prove that it has to be less than 55, that magic number?
Yeah, so that magic number came from the Improve It trial, which was an ezetimibe study. So it was high dose simvastatin plus ezetimibe, and there was better outcomes when you got their LDL was around 53 in that trial on the target LDL. 55, though, has been validated in a number of trials. Primary prevention, the new Vesalius trial. Vesalius is that, I mentioned that score above 100. They got LDLs to 45 and reduced events by 25%. And the Fourier trial and the another outcome study, which I'm blank on for the moment, with the alirocumab, Praluent, both of those trials, Odyssey outcomes, showed that if you get LDLs down into the 30s, they have even better outcomes. So we have a number of studies that have achieved LDLs less than 55, but the main trial that drives us there is called Improve It.
The second question is cardiac CT angiography. Who's going to be reading it? Is the radiologist or the cardiologist?
Well, so it just depends on where you are. So there are expert radiologists who read this really well. There are expert cardiologists who read this very well. At my site at Harbor UCLA down in Torrance, cardiologists read the studies only. But if you go to main campus UCLA, only radiologists read the studies. But then if you go to the West LA VA, only cardiologists read the studies. So it just depends on where the expertise is. It's just like nuclear. Nuclear cardiology, we call it, but nuclear medicine, stress nuclear, 50% read by radiologists in the US, 50% read by cardiologists. So it just depends on who the expert is.
All right, again, in the interest of time, but I have to ask you one other question. You brought up the aspirin. Nobody knows what to do with aspirin. Well, and I know you have some interest in colchicine, but we said yes for colchicine, then no for colchicine, then yes for colchicine post-MI. So where are we with that?
Yeah, so colchicine's a tough one. So colchicine, stable coronary disease, 3 big trials all show positive data. And when you do a meta-analysis, it's 25% less events. That's low-dose colchicine. So normally for gout, we use 0.6 BID. Here they used 0.5 once a day. 0.5 is a brand dose, but 0.6, the generic colchicine dose, you can use it once a day. That shows a 25% benefit. It has a class 2A recommendation in our guidelines because it didn't reduce cardiovascular death, but it did reduce MI, stroke, and revascularization. So I use it for vasculopaths. For people who have a lot of vascular disease, I add it in. It's very well tolerated and very safe at 0.6 or 0.5 once a day. Acute MI, we tried using it in acute MI, a trial called Clear Synergy. Within 24 hours of an MI, did not work. But that might be a process of you don't want to inhibit healing while somebody's having an acute MI, and there is an anti-inflammatory process with colchicine. We were always taught never give steroids during an acute MI, and now they gave a weak version of steroids during an acute MI, and it didn't work, and they're like, oh, this is a bad drug. But I think it's just a timing thing. So don't use it in the first 48 hours of a heart attack, but chronically, I do add it in some patients, the really high-risk patients.
Thank you.